I train a lot of residents, and so these are the things I tell them. And like I said, hopefully when you are back in the operating room, there might be a pearl or two that you can take back with you. So we'll just talk about some of these anatomic pearls, briefly how much ethmoid surgery to do, and then some of the danger areas in sphenoid surgery. Oops, hey, even better, okay.
One second.
I was telling them these videos are fresh in that I tweaked them a little bit even this morning, and then they are running, and Greg said I have exactly 20 minutes, so I'm going to fast forward through a few of them. So we've got a handout that we give patients to show them what we're going to do, because this is just sort of a vague idea to them. There's some stuff between your eyes that we're going to open up, and they get a handout, and then this is the picture in the Mayo booklet. And I say, your sinuses are going to look just like this after surgery, which is, of course, like beautiful and perfect, and it's never quite that easy. But I try to show them where we're going. We're going to concentrate mostly on the ethmoids and then the sphenoid. And I'll just quickly outline the steps I take the residents through. And like I said, I hope a couple of these pearls might stick with you. First, the uncinate, which Brad talked about first, but again, just to briefly review, because you got to get the uncinate all the way down to do the ethmoids. We're going to find the lamina. That's our ethmoid bulla landmark. Get through the basal lamella, inferior and medial. We're back in the posterior ethmoids. We're going to find the lamina again, and then talk about a couple ways to get to the sphenoid. So first, the uncinate, which we just talked about with the last talk, important for maxillary surgery, but also important for the ethmoids. Pushing that turbinate, you can see the uncinate. Let's see if this is, and then the bulla right behind it. I don't crank on that turbinate. I don't like to crack it. You can gently medialize it with your instruments while you're working. And this is a picture from my partner, Dr. Carlos Pinheiro Neto from the lab. This uncinate is behind this turbinate. This is the middle turbinate. If you take that away, you see this uncinate here and then the bulla right behind it. I'm going to show you my uncinate model that is with you all the time. This is your uncinate. I tell the residents, hold up your hand. This is your uncinate. Your maxillary sinus is right here on your thenar prominence. I say, this is what we have to find. So you got to take the uncinate down to find the maxillary sinus. So I tell them, like, you have got your uncinate model with you always. I didn't realize until Brad said it, there's actually a name for this, Parsons technique, I guess, he said, to take down the uncinate. So gently pushing the turbinate medial. Now we're seeing the uncinate and the bulla. I was taught by Don Leopold, my fellowship director, like, we want to just gently medialize that uncinate. This is that ball probe. I'm not trying to stick that into the maxillary sinus. I'm just feeling that edge. I'm literally just using the ball. I want to see where it hinges. That's that maxillary line. This is a pediatric terrier backbiter. So I tell the residents, we're going to cut right here in the corner of our uncinate. We're pulling it away from the lamina, and then we're cutting. Some people use a sickle knife. I'm not really a fan with trainees of using a knife to cut the uncinate towards the eyeball. I'm always working away from the eye. And so we make this cut in the corner here. You can continue that cut superiorly if you want. I love the microdebrider. I could do basically an entire sinus surgery with just a microdebrider. And so I'm going to show you lots of microdebriding here. The rules of microdebriding: you always see the opening. You never plunge it in where you can't see it. I'm taking off the vertical portion of the uncinate. I'm going to also take off the horizontal portion of the uncinate. And I'll fast forward just a little bit here. This person had a balloon procedure. We could see that that balloon didn't go where it was supposed to. This is why he's having revision surgery, because he still has disease. So taking more uncinate off, you can start to take it up towards the auger. But we want to take that all the way to the maxillary line. And the reason why this is so important is because you want to be able to see that ethmoid bulla, which is behind us there. And we'll see here, there's the natural os. So I realize this is like cutting into how to do a maxillary enterostomy. But like I said, to have a good ethmoidectomy, you want to be able to see this is the bulla, there's the lamina. So again, here's just a still shot. That uncinate is gone. There's the bulla. That's the retrobullar recess. And we're starting to see the basal lamella. So to do an anterior ethmoidectomy, you want to start with that view with the uncinate gone. The next step is we want to take that bulla down. And this is that find the lamina step of the anterior ethmoid artery. I have some residents like otology more than rhinology, so I say, the lamina is like your tegmen. You have got to find that when you're doing a mastoidectomy to stay out of the brain. You have to find the lamina to stay out of the eyeball. And I think some people get nervous about getting that close to the eye, so they don't take this all the way down, but you want to fully expose that to be safe. This probe is towards the retrobullar space. You can use a curette here. Frankly, I just microdebris that off also. We're starting to see the basal lamella here. So again, I'm sort of a one-trick pony here. I like to use the microdebrider. So I know the rule is like don't use it near the eye, but I have my residents learn how to use the microdebrider everywhere so that they are safe using it. This is working on those anterior ethmoid cells. I am pointed towards the lamina, but I can always see the door. I'm not plunging in. We want to get this completely cleaned off. This person had a very extended maxillary sinus. The other thing about taking off the bulla, you want to make sure you get the whole medial side. So I sometimes see patients, I'm revising their surgery, someone has gone right through the middle into the basal lamella, but they haven't removed this medial wall of the bulla, so you want to make sure you get that whole bulla off. You want to completely expose it over to the lamina. You've got your maxillary sinus down here, your lamina is fully exposed, you're going to see the basal lamella here. You can start to take this upward towards the skull base. I'm going to clean that skull base off completely later though, because I'm working on the skull base posterior to anterior, but I'm getting it cleaned up enough so that I have a big wide view here. Middle turbinate, lamina, maxillary sinus, basal lamella. So basal lamella, important landmark here. I will admit as a resident, I was like, I don't know exactly what shape that is because it seems like it goes every which direction. On a sagittal view, it's easy to see here. This is middle turbinate. This is that basal lamella here behind your bulla. Separates the anterior and posterior ethmoid sinuses. And so just briefly to say, how much ethmoid surgery? Well, sometimes it is just the anterior ethmoids that you need to do. Odontogenic sinusitis, just the anterior ethmoids. Sometimes if you have some very isolated osteomeatal complex disease and you're doing a maxillary enterostomy, you may want to open up the bulla for that also. Some disease, you need all of the ethmoids completely open. Some CRS without polyps, with like chronic cough and bronchiectasis, they just have thick mucus, you just need to rinse it out. Take all the ethmoids. Really bad polyp disease, you're gonna do all the ethmoids. Getting all the auger cells and the suprabullar cells and those really high anterior superior ethmoids for frontal disease. This comes back to the how much ethmoid disease. So the basal lamella is that boundary between the anterior and posterior ethmoids. This is a gentleman who on a coronal view has frontal, anterior ethmoid, and maxillary sinus disease, and here's the culprit. This bad tooth, periapical disease, already had a filling, but the tooth is bad and has disease from the maxillary sinus extending up into the anterior ethmoids and the frontal. Odontogenic sinusitis, generally does not go through the basal lamella. So this gentleman's surgery is only anterior ethmoids. And sometimes if you see on a sagittal, it doesn't go into the posterior ethmoids, look at the teeth, because a lot of times that's the pattern for odontogenic. Okay, so like I said, basal lamella, it's easy anatomy. Looks like it in this picture, but here's another publication of all the different shapes. So I recognize like the configuration is a little bit tricky, but the bottom line is there's a vertical portion and a horizontal portion. And I like this. I make my residents do some origami in the operating room. This is the front of the middle turbinate. This is the vertical portion and the horizontal portion. So if we're looking on a left side, we're going to come through this box of the basal lamella to get to the posterior ethmoids, and we do it in this medial inferior location. And this is a picture from Dr. Cassiano's dissection guide. Maxillary antrostomy has been done. Here's the anterior ethmoids dissected. This is middle turbinate. This is the vertical portion of the basal lamella. This is horizontal portion. This transition here, this bend, we're going to come through here. They have the green line sort of in the middle. I'd rather come a little bit more medial, but that's the safest place to come through, to stay away from the eye, and to go in a trajectory that's posterior and not superior towards the brain. So this patient, and we were looking at his anterior ethmoids before. We did his maxillary, opened up his anterior ethmoids. His configuration is a little bit different. He doesn't have a very broad attachment of the basal lamella, at least for that horizontal portion. But we're going to come through. We've already taken off the bulla. This is essentially his basal lamella. We're going to come through medial and inferior first. You can go through, we call it the J curette. It's like a straight curette is one way to come through and open this up. Again, your push or your force vector is away from the eye and away from the skull base. We're coming through that basal lamella. Ideally, next we would see the superior turbinate. Since we already know our lamina, we can then come through medial and inferior, extend it towards the lamina, and then extend it upward. And the things you want to see, like I said, you want to see superior turbinate. You want to get into the posterior ethmoids. Now that we're through, we can start dissecting those posterior ethmoids. Again, I can see my lamina. I'm not plunging that microdebrider in where I don't have good visualization. I've seen the superior turbinate. I can trim the bottom of it off. I tend to trim that lower third so I can start to see the sphenoid opening. And we'll get to that a little bit more. I'm opening up these posterior ethmoid cells. I do use navigation. I do like the navigated microdebrider, partly because I have trainees, and so I can see where they're going. But now we've got those posterior ethmoid cells open. So again, it's find the lamina. This is an opposite side here, but again with Dr. Cassiano, we are going to work towards the sphenoid. We want to open up the posterior ethmoid cells. There's the roof of the maxillary sinus. The sphenoid is at the level of the roof of the maxillary sinus. You want to open up this basal lamella. It's going to be like a box. That whole box of that horizontal portion, vertical portion rather, is gone. You can extend it down a little bit more. This is again going to be the level of the sphenoid. You're opening up those posterior ethmoid cells to find the lamina, and then you can work on the sphenoid. So like I said, find the lamina again. There may be some variations in the anatomy, and one thing to watch for is sort of this, some of these posterior ethmoid cells extend pretty deep inferiorly. You want to make sure you open up those cells completely. Look at your scan, see your orientation or your configuration of your orbit to your maxillary sinus. It can vary quite a bit. It can be pretty much a straight, smooth lamina. but it can extend way back over the maxillary sinus. You want to make sure that when you're doing your posterior ethmoidectomy, you get those completely open, because I do see a lot of disease inferior here where the bottom of these posterior cells aren't completely opened and stuff accumulates there. So make sure this whole posterior wall, posterior ethmoid wall is taken down. So this would be beautiful. This is ideally what we want, and hopefully we will get there where our lamina is completely clean, our basal lamella is taken down so we can see the posterior ethmoids, and we've got this clean box here. So getting to the sphenoid, we know it's about 7 centimeters back, 30-degree angle, 1.5 centimeters from the top of the choana. I tell the residents there are 2 ways to get there. You can go through the ethmoids, like we were talking about. Take down your basal lamella, the top of the maxillary sinus, medial and inferior here. That's the trajectory to the sphenoid. But if you're having trouble finding it, then go transnasal. This is your superior turbinate. You're going to find that os. You can use both techniques to get to your sphenoid. These pictures from Dr. Chu's dissection. You've got the maxillary sinus. Here's the superior turbinate, like I showed briefly before. Trim the bottom of that. You're going to find your sphenoid os, and you're going to open it if you're going trans-ethmoid. This is a different patient. He's got chronic sinusitis, really diseased mucosa. I'm going to show you 2 ways to get to the sphenoid. So we've dissected the posterior ethmoids. Superior turbinate's here, but it's a mess in there. It's bloody and it's inflamed, and I'm not finding the superior turbinate. That's because this gentleman has a huge fungus ball in that sphenoid. There's pus, it's inflamed. We're going transnasal. I can't see the edge of that superior turbinate really well, trans-ethmoid. So I just push the medial turbinate laterally a little bit. I've got my 0-degree scope on. I see the superior turbinate. I see all this disease. I'm going to come in with the microdebrider because, again, it's my favorite. And I'm going to trim the superior turbinate and get into the posterior ethmoid and the sphenoethmoid recess transnasal. And as we take off the bottom of that superior turbinate, we're going to start to see in that superior meatus the posterior ethmoids. And the residents need this technique also when we're doing pituitaries. We go transnasal, trim that superior turbinate, find your sphenoid. Dissecting a little bit more, we're opening up these posterior ethmoid cells from the medial aspect. Let me go back a second. If we now are trans-ethmoid on this same patient, now we're going lateral. Here's the sphenoid that I had found. There's still a little bit of posterior ethmoid cells. I can open those up and clean that up. I'm back to transnasal now and can open up that sphenoid. Okay, couple of things to watch for if you're doing a sphenoidotomy. This posterior septal branch from the sphenopalatine artery, if this is a right side, SPA, sends that branch across the face of the sphenoid and onto the septum. This from the opposite view on the left. Sphenopalatine, posterior septal branch onto the septum. If you're doing a sphenoidotomy and you're coming way down, the odds are you're going to hit one of those branches. These are the branches we need for our nasal septal flaps. We know those are robust arteries. So if you're coming down, be aware that you may come across that vessel. I have on all of the sinus sets we have these bayoneted bipolars. They're not my favorite, but they're on every pan, and the cord is always available, and I have them. So on that last gentleman where I showed I was doing the sphenoid, we had to cut down pretty low to get this fungus ball out. This is a gentleman I don't want to have a bad bleed. He's elderly and he lives 4 hours away from Rochester. So I went ahead and cauterized that. So have some cautery on your set available to get that branch if you're doing a sphenoid and coming down low. The other thing I was going to say about the sphenoid, let me go back one. your sphenoid os, let's look on this side here. This is the medial side of that sphenoid os. I tell the residents, again, to use from a different specialty, I say this is like the anterior commissure of your sphenoid. I don't like to take that medial wall off. I want to save some sort of normal, natural mucosa and not scar it. So I'm going to extend superiorly and laterally to make that sphenoidotomy and ideally leave that medial side alone. A couple other, just in the last 47 seconds, just briefly talk about some other things to watch for if you're doing sphenoids. Look on your scans for an anode cell or a suprasphenoid ethmoid cell. If you're looking at a coronal view and you see a horizontal septation in your sphenoid, that's likely an anode cell. Look on your sagittal to see if that ethmoid extends above it. Your sphenoid os is going to be lower than you might typically expect because that anode cell makes that sphenoid lower. So look for that os. Again, you might go transnasal to find that. I was asked to talk about the dangers in the sphenoidotomy. Again, from my partner Carlos, you're not going to have a sphenoid this big unless you're doing skull base, but the arteries are here. Obviously, if you're working in the sphenoid optic nerve and carotid, no microdebrider goes back in this part of the sinus. And again, just to highlight the things we want to stay out of in a sphenoidotomy. I'll just say briefly, we're going to finish the ethmoids going back to front, but things to watch for as we're working on the skull base, the anterior ethmoid artery, look at your scans. Is it at the skull base, this artery, or is it in a mesentery? It comes out of the orbit and extends more anterior, so it's at an angle. You can see it on your sagittal view if it's low, so be aware as you're working on the skull base. I will skip the video for time, but once you've got your lamina, you found your skull base posteriorly, you're working back to front. I'll show it in the pro section. I knew this was going to be quick, and if I was worried my videos wouldn't play, but this is a sort of a backup. My kids don't think I'm cool. They aren't impressed I was on the math team, but I will say the one thing they're like subtly impressed about is I do a video on YouTube, functional sinus surgery with a microdebrider, and we're at 231,000 views. So if you want to watch me again go through videos, you can find me on YouTube. They're like, I mean, I guess that's cool. And so I'll take it. So anyway, thank you.
Any questions for Dr. O'Brien as we transition?